All right. Good morning, folks. Welcome to Grand Rounds. I'm going to begin with our land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. So today our presenter is Dr. Melanie Bechard. Dr. Bechard is a pediatric emergency physician at CHEO and an assistant professor at the University of Ottawa. Dr. Bechard completed her Master in Public Health degree with a concentration in health systems and policy at Johns Hopkins University. She is currently the chair of Canadian Doctors for Medicare, a non-partisan organization of physicians advocating for an equitable, evidence-based, and sustainable healthcare system. Dr. Bechard's broad research interests include injury prevention, health economics, and equitable access to care. And she doesn't know that I'm going to say this, but I happened to hear Dr. Bechard on CBC radio a few weeks back in a little bit of a tussle conversation with I forget who else. And I have to say you acquitted yourself very impressively, Mel. So well done. The title of her presentation today is Fixing Canada's Health System. So that seems like a pretty simple thing. So we're going to hear all the solutions in the next hour. Good luck.
Thank you so much, Dr. Ryder. All right, let's get into it. Let's fix Canada's healthcare system. I have no financial conflicts of interest. As Dr. Ryder mentioned, I'm currently chair of Canadian Doctors for Medicare, and from the title of the organization, you might guess that I am indeed a big fan of public Medicare. But this love is very conditional. First and foremost, like all of us, I'm a scientist and motivated by evidence, and we'll go through some of the nuances for what the evidence says about how to structure your healthcare system. I would like to acknowledge Alex Munter for speaking with me and sharing some ideas for this presentation, and Rachel Dunnigan for allowing me to present today. So today we're going to cover health system anatomy, take a look at Canada's health system performance, and also spend a lot of time on proposed solutions. We won't cover every single solution. I think that there's a lot to be done to fix our healthcare system, but I've tried to focus on some high yield ones. The talk today is motivated from an experience I had recently, and I'm sure we've all had similar experiences in our respective divisions, where I just come back from vacation and I was doing a night shift. And at about 11:30 before starting the night shift, I decided to take a look and see what the department was looking like. And at the time, we had 71 patients waiting to see a physician, 8-hour waits, and it turned out that I was the only staff MD scheduled for that evening, as is usually the case, but I also had no learners or fellows. This was the highest number of patients waiting to be seen I'd ever personally seen until Dr. Lozier just said this morning that last night they had 77 in the department. So it seems like whenever it can't get worse, it does. And I know that all of our divisions have been dealing with similar struggles. And they make me think, at what point is our healthcare system actually broken? Now, in order to understand whether or not something is broken, it's important to first understand the anatomy. For example, is this a growth plate or is it a fracture? Now, if we know our anatomy, we understand that this is a growth plate. So don't say we didn't cover any clinical medicine today. There's a reason why we cover anatomy first thing in medical school. It provides a basis to understand diseases and treatments, and health systems are no exception. What is really nice about health system anatomy is that it is very simple, and there's two main components to consider. One is financing of healthcare. This is simply who pays for healthcare, and it can either be public, meaning from government sources like our OHIP buildings or RAMQ, or it can be private, which can include funds from private insurance companies or patient out-of-pocket payments. The second aspect of health system anatomy is delivery. And this is simply who is actually delivering the healthcare. Once again, it can be public or private. Public delivery can occur in government-owned institutions with government employees. Private delivery occurs in standalone institutions with people who are not government employees. And of note, the delivery can either be private for profit or private nonprofit. So when we take a look at financing delivery and public versus private, we get a little bit of a quadrant to better understand and compare health systems. Of note, health systems are far too complex to either fit into any single quadrant entirely, but it provides us a bit of a framework. So if we look at the care we actually deliver at CHEO, it's pretty much mostly publicly financed through government funding, but very much privately delivered. We're not government employees. We're, by and large, for physicians, independent contractors. And that's because CHEO, like many hospitals in Ontario, is a standalone nonprofit institution. In other provinces and territories, the hospitals can be run by provincial health authorities and have a little bit more of a public delivery aspect to them. But in Ontario, most hospitals are private nonprofit institutions. So whenever anybody talks about privatized healthcare, it's very important to discuss whether or not they're speaking about financing or delivery. An example of public financing and public delivery can occur for most of the United Kingdom National Health Service, or NHS, where the physicians and healthcare providers are actually typically government employees and the care is often publicly financed. And to think of an example of healthcare that is typically privately financed and privately delivered, we can think of private insurance payments in the United States. Again, there's exceptions to all of these. The NHS has been contracting out more to private institutions. The United States definitely has some public funding for healthcare in terms of their Medicare and Medicaid payments, their Veterans Affairs hospitals, but it provides a bit of a framework. So here's a question to get us thinking, and it's a true or false. Does Canada have universal healthcare? You can think on that for a second. Prior to a few years ago, I probably would have said, yes, absolutely. That's kind of our whole thing, isn't it? However, the answer is actually really, it depends. And a better question is, does any country in the world actually have universal healthcare? There's actually 3 distinct metrics we use to determine universal health coverage in a country. So this is a bit complex, but we'll go through them one by one. First off is financial protection. What do people have to pay out of pocket? Sometimes you only have partial coverage for your healthcare. So for example, I technically have some private insurance for medications, but it doesn't cover the entirety of my migraine medications. So I have partial financial protection when it comes to those outpatient medication coverage. Second is what services are covered. There's no health system in the world that covers absolutely every single health service. In some lower income nations, they've tended to prioritize maternal or newborn health care or certain acute care services. In Canada, we have actually pretty good coverage across hospital care and physician care, but I think all of us will be aware of the many services and gaps that exist. For example, when patients are discharged from hospitals, typically they won't have any coverage for their outpatient medications. Now, this is improved in Ontario with the advent of OHIP Plus, which we'll be discussing shortly, but for the adult patients, there's some pretty significant gaps that exist. Similarly, long-term care, dental care, these are areas where private healthcare and private pay healthcare still plays a major role for most of us. And then last but not least, who is covered? What is the population covered? Does everyone in the country have access to healthcare? Is it only people below a certain income level or people below or above a certain age? When we look at these elements, we can kind of determine where we're having our gaps in our healthcare system. Let's move along now to healthcare performance. And we'll definitely have some time at the end for questions and discussion, but if anyone does have any burning questions right now, please feel free to comment in the chat. I've divided up health system performance into the before times and the after times, because I think we recognize that, like all healthcare systems in the world, the COVID-19 pandemic really strained our healthcare system. So some of those performance metrics do differ. But if we look at before the COVID-19 pandemic, back when we all were full of hope for the year of 2020, we can take a look at population coverage as a metric of Canadian healthcare. And on this, we actually do pretty well on a global scale. In Canada, it's estimated that about 1.4% of the population is uninsured. These are largely newcomers to Canada who have a 3-month waiting period until health coverage kicks in. This actually was suspended for a bit during the COVID-19 pandemic, but I believe that 3-month waiting period is coming back. It could include undocumented individuals, people who are refugee claimants whose claims have been denied, These are individuals who might not be entitled to the same health coverage that Canadian citizens have. So this amounts to about 250,000 to 500,000 people. And these are based on estimates because it can be a very difficult population to include in census. Compared to an international level, we actually do fairly well in terms of keeping our uninsured numbers relatively low, although of course we could always be better. That's still a sizable amount of people. If we do compare ourselves to the United States, of course, they have about 14% of their population, or 46 million people, who do not have access to either public or private healthcare insurance, which actually is larger than the population of Canada. So let's take a look at some of the dollars and cents. I always thought that Canada had the most expensive healthcare system in the world after the United States, but it's actually more complex than that. When we look at percent spending as a percent of GDP, Canada's health spending is about 10%. The United States is a major outlier, unfortunately, at 17%. So we'll just kind of ignore that for a bit. But if you look at other high income Western nations that we often compare ourselves to, we're fairly middle of the road in terms of the total health expenditure as a proportion of our GDP. What's also interesting is when we look at the proportion of health spending that is from public versus private sources, Canada has been fairly consistent at having 70% of our health spending from public sources and 30% on financing. When we look at other healthcare systems like the UK or France or Denmark, all of which can have realms for second tiers of healthcare, we can actually see that they spend a higher proportion of health spending from public sources. So our proportion is actually fairly small. And when we look at the proportion of health spending that comes from patient out-of-pocket charges, we're at 13%, which is shockingly, I think, higher than the proportion of health spending from out-of-pocket sources in the United States. I think some of this might be due to deferred care or care that never happens altogether because of the high healthcare prices in the United States. But if you look, we're actually quite higher than many other nations in terms of out-of-pocket spending. So this is coming from those gaps in service coverage that we spoke about, things like outpatient medications, dental care, physiotherapy, all being big contributors to the out-of-pocket expenditures. Now, we have a major problem with pharmaceutical spending in Canada. About 17% of our health expenditure is on pharmaceuticals, which is disproportionately high compared to all other nations listed here in this tiny sub-segment of the OECD. And traditionally, we have been second or third highest in the world after the United States and Switzerland for our pharmaceutical spending. I have some updated data which suggests that we might be moving in the right direction, but this is an area where we truly overspend in Canada. Now, this is always a bit uncomfortable to think about, but in Canada, as physicians, we do tend to be more highly remunerated compared to many other countries, with, of course, the exception of the United States. And nurses tend to be relatively underpaid compared to some of these other nations. When we look at organizations for health technology assessment, Canada, like many countries, does have an organization called CADTH, the Canadian Agency for Drugs and Technology in Health, that evaluates new technologies and new treatments and determines if they're evidence-based and cost-effective. So this helps to ensure that when things are covered under provincial territorial health plans, they're actually bringing some additional benefit. They're not just rehashing same things that the drugs in the market already do. The United States does not have any agency like that. So it is a hotbed for innovation. There will be a lot of drugs and technologies put in the market, but some of the overspending in United States healthcare, I think, is related to the fact that there's not this mechanism for evidence-based decisions. And that's not to say that our process is perfect either, but it is helpful to at least have some guidance. All this to say is that multi-payer systems do tend to have higher administrative expenses. In a single payer system, which Canada largely is, things tend to be a lot more administratively simple. And it makes sense. You can imagine that if you're chasing down insurance companies all the time to procure payment from patients, this ends up being a lot of work. It creates entire jobs and industries and leads to a bigger proportion of healthcare expenditure that is due to administration rather than other causes. Yeah, and I see here a comment that NHS physicians have pensions, which needs to be taken into account. Exactly. When you have more of a physician's salary system, they are treated more so as employees and typically will be more eligible for pensions and benefits. In the United States and Canada, that's typically not the case. All right, so let's get into the good and bad and ugly, and some of the ugly about Canada's health system performance. So when it comes to these comparator OECD nations, we look at the share of people who are not able to contact their family doctor's office or get a response from them on the same day, and we're amongst the highest in the world. About a third of people say they can't hear from their family doctor on the same day. And I believe this is out of people who actually have a family physician, which is becoming increasingly difficult, particularly in Ottawa. When we look at the percentage of people waiting 1 month or more for a specialist appointment, we are once again amongst the highest in the world, or at least amongst these OECD comparator nations. So we do have some issues with wait times. What I think is surprising to a lot of people, though, is that our surgical wait times, at least pre-pandemic, were actually slightly lower than the OECD average. So when we look at cataract surgery, Canada's here in this red box, and the OECD average is a few days higher up over here. Same thing with hip replacement. Canada's just about at the OECD average. And same thing with knee replacement. And of note, this is after you've seen the specialist to when you can actually get the surgery. So the issue of wait times in Canada is clearly a little bit more complex. And when we look at more urgent surgeries like coronary bypass, we actually have amongst the lowest wait times in the world, which was a pleasant surprise for me. The OECD average tending to be 24 days, and Canada's average tending to be about 6 days. Same thing for prostatectomy. For prostate cancer, we are once again well below that OECD average. So it's clear we have a problem with wait times in Canada. There's not a country in the world that doesn't have wait times for healthcare. It seems as though we've tried to prioritize our scarce resources towards those that are more urgent, but that is of course not to belittle the suffering of anyone who's waiting for cataract surgery or knee or hip replacements. These things can extremely limit patients' function, and we don't want to have people waiting on wait lists for months at a time to receive specialist care or healthcare. So this definitely is an issue. Where we have had some success is making sure that our wait times are equitable. There was a study done at Sick Kids back in 2014 that looked at all surgical referrals by SES and found that your socioeconomic status does not affect your surgical wait time. There was a similar study done in 6 Vancouver hospitals around the same time that looked at general surgery referrals and found once again, SES doesn't affect surgical wait times. And then there's a more recent study that came out just earlier this year in BMC Health Services Research that looked at from 2006 to 2015, surgical referrals across all of Ontario, and they've essentially color-coded patients from those who were least deprived, or bluntly tended to be richer, have more financial resources, and those who are most deprived, bluntly those who tended to be poorer, have less financial resources. You can see there's very little difference between these various socioeconomic quintiles. What I find quite interesting is that the least deprived or richer patients, if anything, actually had slightly longer wait times, an order of magnitude about 3 days or so in 2015. So we do a pretty good job at making sure that when it comes to surgical referrals, our system is relatively equitable for wait times. This doesn't account many different markers, of course. We know that there's huge gaps in service coverage amongst certain marginalized populations, amongst rural people, but at least by socioeconomic status, we seem to be fairly equitable. So that was before 2020. How has healthcare changed after the dumpster fire that was 2020 and the pandemic? I think these headlines are all familiar with us. This is an article about wait times at CHEO, which revealed that our emergency department wait times were 3.4 hours compared to an Ontario average of 1.9. I was actually pleasantly surprised by 3.4. I think these days it's rare if we can see patients in 3.4 hours, all but the most acute. MRI times in the pediatric healthcare system are actually 4 times longer than for adults, and mental health care waits for pediatric patients were 3 times longer than adults. So it's clear that Canada has an issue with wait times. And what I think is surprising to many people is that it's particularly bad for pediatrics. And of course, you know, like all of us here, I'm interested in child health, so maybe I'm a bit biased, but I think that children's health is even more important to minimize wait times because kids have such sensitive periods of development. And if they're not at optimal function, truly can affect their whole life trajectory. I, as an adult, would rather wait longer for an MRI or treatment than having kids on wait lists for 4 times as long as I am. Now, we've also seen a lot in the media about the exodus of family physicians and all the Ontarians who could be without a family doctor. There's a study done by Camila Premji at Western University that found about there could be over 1.8 million people in Ontario without a family doctor before 2025. And there was also a study done that looked into the pandemic from March through September 2020 and found that 3% of family physicians had actually stopped their practice during the pandemic. This amounts to over 380 family physicians or 170,000 patients left without a family doctor. What I want to make clear is that we absolutely can't blame family doctors for this. I'm a huge fan of those who are providing primary care. I think it's the most difficult job in healthcare, hands down. And that's largely because of the way we set up family practice. The way we structured our healthcare system, we really are dependent on family physicians as gatekeepers and managers of the healthcare system. And if we don't have family physicians, the whole system is falling apart, which I think we're seeing right now. When we compare ourselves to other countries, it's both good and bad to know that other nations have also struggled with wait times during the pandemic. So in the United States, when we compare post-pandemic to 2017 as a baseline, surgical wait times have increased by anywhere from 7 to 48% for these various specialties. Similarly, when we look at Finland, which generally has a very strong healthcare system, surgical wait times increased by 1/3 during the pandemic. And we would look at Australia, which does have a two-tiered healthcare system and does have a private parallel pathway for care. We can see that the percentage of patients waiting more than 365 days or 1 year for surgery has really skyrocketed in this post-pandemic 2020 to 2021 period across all regions of Australia. So it's both reassuring and also sad to know that we're not the only country that is struggling with worsened wait times during the pandemic, largely driven by health human resource crisis and higher patient needs. One bright spot, so that not everyone becomes too depressed, is that when we compare ourselves to pandemic performance, we actually have done pretty good across different metrics. When we look at the proportion of the population that's been fully vaccinated against COVID, Canada's amongst the highest in the world at 80%. And when we look at the cumulative confirmed COVID deaths per million, Canada's relatively low compared to many of these other nations. Not quite as excellent as Japan and some of the other Asian countries that had more strict lockdown measures, or I should say public health protections, but still doing fairly well compared to our peers. And this is from an article that came out in the CMAJ earlier this year. And the authors posited that having our universal public accessible healthcare, knowing that there is, of course, a major caveat on that word universal, has really contributed to people being as healthy as possible during the pandemic and contributed to at least preventing some excess deaths from COVID-19. So that's kind of the state of healthcare right now. I see that there's some comments here, the cost of medical school in the US. Yes, the cost of medical school in the US is absolutely astronomical. Cost of university in general in the US, so particularly if you're doing an undergrad or even a master's degree beforehand, is staggering. So it does make sense that in the United States, the physicians would have some higher compensation, and it's not even proportional to cover the cost of student debt compared to what we have in Canada. Yeah, and I see Fahad here mentioning that billing codes make family medicine unsustainable to work in right now. It's very true. That's exactly what I've been hearing from primary care doctors. I'm always reluctant to speak on behalf of primary care doctors because I'm obviously not one. I'm just a big fan. But we're hearing that it's really set up by and large, with some exceptions in Ontario, as a fee-for-service business model. And the way to deliver family medicine and the way that people are trained to do family medicine isn't in that fee-for-service billing model. Those billing codes are outdated. It's very hard to run anything as a medical practice this day and age, and especially as a business. Yeah, and our students are graduating with an average of 100K of debt. I think the last figure I saw here in Canada was 120K in debt. So it's still pretty bad. Yeah, so it makes sense that that is part of what contributes to our higher salaries. But one might say, okay, if we don't want to reduce healthcare costs, how can we reduce the cost of medical education in the future? Does that mean that maybe there's room to pay physicians less? That's not anything I'm necessarily advocating for, but I think that really anything goes in this conversation because our current system is more expensive than it can be. All right, let's look at solutions. It's important to be optimistic. We've covered a lot of problems. When we look at health system solutions, I think there's two major categories. One is to increase funding, or at least target funding, and money is definitely an important part of the equation. Another one is reorganizing care. And unfortunately, I think that this is what governments tend to spend a little bit less time on because it does tend to be more complex. It does require, I think, more knowledge of their healthcare system. It can be very politically popular to say, we're investing X number of dollars into healthcare without any real idea of exactly where that money will be going, what the impact will be, what the outcome metrics will be. I think we're getting a bit better at this, but really, I would love for governments to also focus more on reorganizing care. So let's focus a little bit more on the spending. And as we've already covered, in the OECD, the average percent of GDP spent on healthcare is about 9%. So we are slightly above average there with our about 10% or so. And when we look at the breakdown of spending from public versus private sources, in general, the average is about 73% from public sources, 27% from private. So we do tend to have this shifted a little bit so that we have 70% public, 30% private traditionally. That's how we compare to the OECD average. When we compare ourselves to many other countries where we look and think, they have great health systems we should emulate, we can see that typically there's a slightly higher proportion of healthcare spending as a proportion of the GDP, and typically there's more public spending. Now, as we've covered, public spending does tend to be a little bit more efficient. It does tend to make the care more accessible. So I think that this is something that we can look at. Sometimes we'll compare ourselves to other nations and say, oh, they're doing great because they have a two-tier healthcare system where people can pay privately for care. But it might also just be because there is actually more public coverage and less out-of-pocket payments and even more spending on healthcare in general. So I think that's a major confound whenever we compare different countries' health systems. We can see similarly here the breakdown from United States, France, and Germany. All right, so that's financing healthcare. Let's look at how we can actually reorganize care differently. There's actually been a really successful example at CHEO lately with the one call, one click service. So I'm not sure if anyone here was making mental health referrals previously, but when I first came to CHEO as a fellow in 2018, one of the hardest things to learn was all the various mental health and addiction services available in the region. Coming from Toronto, I was not so familiar with everything. I felt like I was maybe never the best advocate for patients because I wasn't so familiar with all the resources. I'd ask around and we'd have info sheets, but sometimes patients would ask questions about which would be the most appropriate service for them, and it'd be challenging. I'd have to plot their address on Google Maps, figure out which catchment area they were in, try and figure out what would work best for them. And also, this is in the pressure of working in the emergency department where you could be pulled away to an acute care case at any moment. One call, one click has really simplified this. Now we're able to do the central intake referral just through one call, one click, and then you get an actual expert intake worker navigator to help patients navigate the system. This is also a lot easier for families who no longer need to do all of that research on themselves to investigate the various possible community resources and find what would work best for them. So in its first year of One Call, One Click, they've received over 5,000 calls, have matched over 4,000 patients with community resources, provided over 500 episodes of community and peer support. This is a relatively simple way for us to reorganize care. One call, one clicks expenses are fairly reasonable to keep it going. It's about $2 million per year, and especially when we consider the impact that this could have on patients and families actually being connected with appropriate mental health resources, I think it's worth every penny. And CHEO has been involved in a lot of these initiatives to reorganize and reconnect with care, largely through the Kids Come First health team. There's now an integrated home and community care strategy, which is looking to make transition to home care a lot more seamless. I don't work with home care so much these days, but I know as a resident, sometimes it would take me all day to try and activate CCAC or home care resources for patients before they could be discharged. And hopefully, as we move forward and coordinate care between all these different groups, that can be a more seamless transition. Now, another way to reorganize care in Canada actually comes from grocery stores. So there's this New York Times article about Whole Foods having really long lineups when they moved into New York, but the lines moved far more quickly. And that's because there'd be a common line and then this one person who would send people to the next available cashier. That's also the way that lineups work in banks. If you think of it, you don't line up for one specific teller. There's a common line, and then you go to the next teller who's available. It's a brilliantly simple idea, statistically is proven to significantly shorten wait times, and is something that healthcare is adopting more and more. So when we look at central intake for surgical referrals, this was a systematic review that was published last year in CMAJ Open. They found it decreased surgical wait time referrals by 57%, internal medicine wait time referrals by 40%, and maintained high levels of patient and provider satisfaction. It actually reduced time to lung cancer biopsy almost in half and reduced time to lung cancer treatment from 118 to 80 days. And this was studied in Newfoundland at Memorial University a few years ago. And even when we look at shorter wait times, this was a study of physiotherapy referrals in Winnipeg for children's medical complexity, and they managed to get the wait time down from 12 to 8 days. And they actually compared this to a standard care program and found that the wait time actually slightly went up. So having a central intake can decrease their wait times. And I'm sure that this would make a lot more sense than what we currently do. Right now, when I have a patient with allergies, I refer them to, the one allergist I know in Ottawa. And I don't know if this person has long wait times or short wait times. I'm sure they're doing a great job, but it would probably make a lot more sense for there to be like a central allergy referral pool for the Ottawa region and have patients go to providers that are available next. Now, of course, there need to be some nuance for this. Maybe certain providers have particular skills or interests and could see certain patients off the list. Maybe some patients aren't able to make it all the way across town because they're limited in transportation. But all of this can be built into our central intake. And I think this is something that we do at CHEO fairly well, being a hospital, we're all connected, but creating these community networks and linking up providers to have more centralized referrals can actually significantly decrease some of the waits we're seeing in Canadian healthcare. Now, the great unfinished business of Canadian Medicare is pharmacare. So as mentioned, Canada's drug prices are very high. I've outlined us here in red, and these are based on the most recently available data that show Canada right now has amongst the fourth highest drug prices in the world. This is actually an improvement. We used to be second or third, just after United States and Switzerland. So there has been some movement in the right direction for reasons that we'll go over shortly. But still, we have a long history of cost-related non-adherence, which is simply patients being unable to take their medications because of prohibitive costs. So there's just a systematic review that came out earlier this year that looked at various studies of cost-related non-adherence in Canada and found that could be anywhere from 5% to even 10 or 15% of patients who were either not filling their prescriptions or rationing their medication or going without other essentials to pay for their medications. And part of this study, which is really heartbreaking, looked at Canadian Community Health Survey data from 2016 and found that people were trading off in other areas of life to be able to afford their medication. So an estimated 2.7% of the population had gone without leisure or vacation. Some of you might think, okay, that's reasonable. But 2.4% actually compromised on food, 1.2% compromised on transportation costs, about 0.8% compromised on heat, 0.7% compromised on housing. These are pretty big things that can affect one's life and are really related to the social determinants of health. So if you're making compromises here to afford your medication, it's probably unfortunately not going to be great for someone's long-term health. When we look here, we can also see that there's some additional healthcare use and therefore costs from cost-related non-adherence. There's an estimated extra 300,000 physician visits, 90,000 emergency visits, and 26 hospital admissions related to people being unable to take their medications. So even if you are someone who is a little bit more, I won't say heartless, I'll say pragmatic, and says, I don't think it's too much of a problem if people can't afford their medications, pharmacare is too expensive. We have to realize that our current system is having consequences, both in terms of human health, but also in terms of unnecessary healthcare use and therefore expenses. There's also a lot of inequities between provinces and territories with our current system. So this was a study done of chemotherapy coverage back in 2019 and found that intravenous chemo, which by and large happens at hospitals, is typically covered across the provinces, but that oral outpatient chemotherapy isn't always consistently covered. Now this was for adult patients, so I'm not sure how well it applies to pediatrics, but you can only imagine that that could be really devastating for somebody with a cancer to not be able to afford their medications. So maybe you're thinking now, okay, I'm kind of into pharmacare, but it's probably cost prohibitive. Well, there's a study done in 2015, one of the biggest studies to cost out pharmacare in Canada, and found in terms of overall drug spending, so this is drug spending from all sources, patient out-of-pockets, government, etc., it would save an estimated $7 billion per year, which is mind-blowing. Now, that is partly because some of the costs would be shifted to the government because federal, provincial, territorial health plans would need to cover some of these costs. They estimate the additional cost to governments would be approximately $1 billion. Not insignificant, but typically government budgets are hundreds of billions of dollars, so it's not necessarily going to break the bank. And what's really interesting is that the worst case scenario is that would cost $5 billion, a very hefty price tag. But in the best case scenario, it actually could save government $2.9 billion. Now you might be wondering, how in the heck would paying for medication actually reduce government spending or save costs? A lot of it is because if we buy medications as a country, we can negotiate lower prices through bulk purchasing. Think of shopping at Costco and buying things in bulk versus shopping for, I don't know, 1 or 2 toilet paper rolls at a time. You're going to get a better deal when you're buying more product at once. And this is partly how Canada's already started to decrease some of the drug medication costs because provinces have gotten together, formed groups, and tried to negotiate on a larger scale. If this were to happen nationwide, we could likely achieve even more success here. As mentioned, when you have a single payer system, you can reduce administrative costs. And we also would have the ability to create a national formulary that would choose the most evidence-based and cost-effective medication. Right now, insurance companies tend to decide which medications are covered, and it might not be the most evidence-based or cost-effective med, which could lead to some waste. We could also encourage more generic substitution too from a pharmacare system. So there was an RCT done looking at giving people free access to medications, and they basically randomized about 786 patients to either receiving free medications or their usual state of coverage. And they found that adherence was significantly higher for those who received their free medications, which is not surprising. Definitely, if you're experiencing cost-related non-adherence, you're going to be more likely to take your medicine if it's cost covered. What I find really interesting here is that adherence is still very low in both groups, but I think that's probably just because the people in the study were honest. Interestingly, at 2 years, they looked at various health markers and did not find a significant difference in levels of hemoglobin A1C, LDL cholesterol, or systolic blood pressure. Now, this is disappointing, of course. Maybe giving medications to people doesn't make them healthier, but I think it speaks to some of the complexity that we have about health and all the social determinants of health, which might have remained unchanged for some of these individuals. However, when we look at healthcare costs, those who did not receive free medications had about an extra $1,100 of healthcare costs over that 2-year period compared to those who got their free medication. So once again, we might be able to make a little bit of an economic argument for pharmacare. I wanted to include this study, which was just published earlier this year, and it looked at changes in hemoglobin A1C in people below the age of 21 with diabetes in Ontario, both during OHIP plus and then before OHIP plus. And they found that for all patients, there was a slight lowering in the hemoglobin A1C during OHIP plus versus before OHIP plus. And OHIP plus, again, is a program that covers medication for youth who don't otherwise have coverage. So it seemed as though it was non-significant. There's a slight decrease in hemoglobin A1C, but the confidence intervals didn't really play out. But when you compared the lowest SES quintile to the highest SES quintile, there actually was a significantly lower drop in hemoglobin A1C and the lower SES group compared to the higher SES group. What does this mean? It means that the patients who are more financially vulnerable seem to benefit more from having medication coverage and did seem to have some positive health effects from that. So I think that's something to keep in mind. Whenever we're making these programs, there's some people that they might not help because they might already have adequate coverage or have the financial resources to access their medications. The people that have the ability to help are probably amongst our most vulnerable. Now, there's so much to say about family medicine and how we can improve it. But one thing that we need to keep in mind is that continuity of care has been shown in multiple systematic reviews to decrease mortality. Having a longitudinal primary care provider who knows you and knows your health actually lowers your risk of all-cause mortality. So we need to support this whenever possible. Personally, I think family doctors should make twice as much as they make. That's not an evidence-based opinion. I think it partly is. I'm not sure what the exact right proportion or spending is, but we need to pay them more because our whole health system depends on them. And, as an emergency department provider, my job gets a lot easier when people are able to access family physicians. When we look at organizing physicians into interprofessional teams with nurses, nurse practitioners, and other professionals like physiotherapists and dietitians, this actually decreases patients' walk-in clinic use and increases their ability to access same-day care. So as much as possible, we want to support these team-based models of care. Now, we're talking about solutions, but I did want to briefly cover some solutions which are kind of band-aid solutions or might not totally work. What we've been seeing across multiple provinces is governments wanting to contract out healthcare to private for-profit sources. The proposed idea is that it will, quote unquote, take the pressure off of the public system. However, what we don't realize is that we're already having major health human resource challenges in Canada. This is partly because of our aging population with people retiring and not having enough people who are entering the fields to replace them. And of course, this has only been worse than during the COVID-19 pandemic. So if you're opening up private for-profit clinics to care for patients, ultimately this draws physicians and nurses away from the public sector and can actually worsen wait times in the public sector. And this is exactly what was seen in Australia and in Germany when they created these second private tiers for care. The wait times actually increased 2 to 3 times longer for patients in the public system. And overall, the wait times didn't really significantly change because they were slightly shorter for the patients who were able to pay for care, but slightly longer for the vast majority of people. So I do think we need to keep that in mind. We also need to know that private for-profit care tends to be more expensive. Studies in Vancouver have found that knee surgeries cost 4 times more in private clinics and MRI scans cost twice as much. There's also an issue too, if governments are paying public funds to contract out for private clinics, the government's essentially paying for equipment for buildings and for capital that it will never own. So that's essentially lost income for the government. We also need to look at some patient safety effects. Now, this is not to say that there's not some excellent private for-profit clinics. I'm sure there's some that do deliver great care, but it is a risk factor for lower quality care. And that's because when you're wanting to make a profit, and especially if you're receiving funds from the public system, there's only a few ways where you can get decreasing staff. If you don't have as many healthcare staff, there's a higher risk for mortality. We've seen this during the pandemic in many long-term care facilities where there's excess deaths in private, for-profit, and particularly chain institutions. There was a study published in The Lancet earlier this year looking at the National Health Service and found that when there was contracting out to private for-profit clinics, there was higher treatable mortality amongst patients. And in the US, when we compare for-profit versus non-for-profit hospitals, there's a slightly higher relative risk of mortality. So those are some solutions for what to do and what not to do to fix the Canadian healthcare system. I want to make sure we've got lots of time for a discussion because I'd love to hear everyone else's ideas. Obviously, we didn't touch upon all the different ways our healthcare system needs to be fixed and decolonized and supported, but some key points. Whenever you're talking about healthcare, remember to keep in mind financing versus delivery and ask public versus private. When we're asking if there's universal healthcare, think of population coverage, service coverage, and financial protection. We need to look into funding our public healthcare appropriately, maybe shifting that percentage of healthcare less from out-of-pocket patients and more so into public sources. And we also need to look at ways to reorganize care, to make it more efficient, to have more of these centralized referral lists, to have initiatives like the one that CHEO is leading with Kids Come First to try and deliver care more efficiently. So that's everything. Thanks for hearing my monologue. I'd love to hear your answers and discussion. Oh, and just before we do that, I'll flip through some of the references. I'm more than happy to share the slides with anyone. The specific references and attributions for all the points are in the notes of the PowerPoint in case you're wondering which specific studies correlate with the different facts. But yes, I'm happy to take any questions and hear your ideas. Thank you.
Thank you very much, Melanie. Definitely some solutions proposed, but none of them, no doubt, as simple as they sound, right? If only it were that simple. For anyone who wants the references, just a reminder that the talk has been recorded, so you can always access Dr. Bechard's talk later also. I will open it up for questions, folks. I will take hands first and then look at the chat. And I see, Roger, you have your hand up.
Thanks, Hillary. Outstanding job, Melanie. Fantastic summary of the whole landscape. One of the things I'd love your thoughts on is I feel that I'm not sure if it's the evolution to the internet where everyone has everything else in their life an instant answer. We can't remember the name of whatever we go to our phone, we get our answer right away. We want to know what's going on in the world, we get our answer right away. For people and especially for parents, speaking with the child lens, that's probably the most important thing in your life. So if you don't have an answer, people want that answer immediately, yet perhaps the demands on the patient's demands are perhaps a bit unrealistic and not as, they're not as patient, not as a patient, but a patients with a CE, they're not showing. And I was wondering, how do we balance that perhaps insatiable need of patients across the spectrum of healthcare to get their answers immediately or right away when that may not necessarily be the most important, which is putting those demands on the family doctors, the emergency departments, which then leads to that. And any thoughts or solutions on how to approach those concerns with the higher demand and the less patience on behalf of our families?
Yeah, absolutely, Roger. I think that's an excellent question. And I think it speaks to the rise that we've seen of some of these private for-profit virtual care apps where people can get a doctor on their phone or doctor on their computer within 5 minutes, because I think that patient expectations are changing, just like you've said. A lot of it goes in line with other industries where, you know, I can deposit a check on my phone in 5 seconds. I don't need to walk down to the bank. Why is medicine not the same way? So I asked the same question too at a seminar where they're speaking about the state of primary care in Canada, and they directed me towards some qualitative studies which show that by and large, patients still seem to want and value having that longitudinal relationship with a primary care provider, and that's still seen as the ideal. But the challenge is that so many people can't access that. And if that's not able to be accessed, then of course they're going to turn towards these other means. So I was also getting a bit worried and skeptical too, that maybe that longitudinal relationship with the doctor who knows you has gone the way of the dinosaur. It seems like the want is there. We just haven't structured our system to fulfill that want. So in the meantime, people are going to want faster answers. I do think that, you know, we are having to deal with these pressured patient expectations for sure, more where people will want the answers. I'm not sure what much more we can do about that other than just being really honest and setting expectations with people in healthcare and saying we won't always be able to get the answer right away. Sometimes things take time to develop. I know you and I share this a lot when we're working in the emergency department, and I'm sure we all have our lines prepared about how, well, we might not know exactly what this is, but we know more about what it's not based on all the tests and investigations. Here's the plan for you. So I think that the expectations will be there, and as much as possible we have to be able to connect people with these longitudinal providers, because maybe that anxiety about not knowing the answer right away will decrease if you know you're going to be able to see the same physician or the same provider in a couple of weeks. You won't have to rehash your whole story and start from the beginning. I think it speaks to more trust, and maybe that trust will enable people to be able to wait a little longer for the answers. But great question, thank you.
Okay, we have Elka, Dr. Miller.
Hi, thank you for a wonderful presentation. I'm going to talk from the imaging part of, and I'm maybe a question or a comment, but there is a reality that we're facing in imaging that the demand has significantly increased compared to the capacity. And in part, I feel, I don't have data to prove it, that through the pandemic, the effect of virtual visits developed in more requests for imaging. Not saying what is right and what is wrong, but checking a patient, talking to a patient, I still feel is really valid. There is also, if for those of us that have practiced longer, we are repeating imaging much more than we used to do in the past. Right or wrong, I'm not gonna go there. We are also, that we do need to work towards helping ourselves in appropriateness. I cannot, as a radiologist, tell any of you that I'm not doing an ultrasound for abdominal pain because I have ethical belief on that I need to help. But on the other hand, you are the guys, there should be a little bit more straight request what we do. The demand on us is increasing at paces that nobody believes, and there's not going to be a system in the world that can make it, even if we work 24/7.
Yeah, thank you for bringing that up, Elka. I think there's so much there. One thing, actually, to keep in mind, if anyone wants a book that touches on many of these points, I really recommend Better Now from Danielle Martin. I was not planning this, it's just sitting on my desk. But one of the 6 ways that she suggests we should improve the healthcare system is through looking more at choosing wisely initiatives. And sometimes this is really difficult to communicate to patients and families because they see it as rationing care. There's still this ethos that more is better, that doing more tests makes you a better doctor, better physician. I see it every day in the emergency department. But really, I think it's on us as stewards of the healthcare system to make sure it's sustainable, to really try and be selective with our tests. I feel like you're going to record this and play it back to me the next time I ask for an imaging in the middle of the night, which I apologize in advance for. But as much as possible, we always want to be very selective with the tests we're ordering. And I think you're right about virtual care maybe being higher risk for more being done, because when you can't actually lay your hands on the patient, it can be more difficult to know with certainty what's going on. There was one study that I looked at for a research project that had looked into this and found that virtual care patients are not worked up more frequently. There's not more antibiotics. There's not more imaging done for patients that are seen in virtual care. But I think this study was done pre-pandemic, and now that virtual care is more widespread, I do think it probably needs to be repeated on a wider scale, because I would suspect that it might be one of the contributors towards increased care, but difficult to say for sure. And I don't want to make any promises because I think the evidence is still being figured out, because virtual care is still relatively new, at least on the scale we've used since the pandemic. But thank you for those comments.
Thank you very much. No, I think it's good to bring awareness with this team especially. Thank you.
All right, we've got 3 other hands up. Let's see if we can get through these questions, folks. So if you can ask your question quickly. Next I have Matt, whoever Matt may be.
I think it's me, Matt Bromwich. Hey, I guess I should change that to Bromwich as well. But anyway, yeah, great talk. Strangely, as an ENT doctor, I've been working with some of the Emerge doctors on maybe like a one access single entry portal to deal with Emerge and what technology would be supported there. It sounds like you'd be a fan because it would support the Kids Comes First initiative. My only question is, please connect with me later.
Okay, awesome. Great question. Thanks, Matt.
All right, okay, bye.
Great, short and sweet. Thanks, Matt. Then next we've got Josh, Dr. Emery.
Hi, Mel. Thanks again for that wonderful talk. So I think a few, like Roger and a few others have touched on this point as well, but along the point of virtual care and the fact that it seems like a lot of newer grads are really interested in the use of this technology, especially to reach more rural patients. We talked about its effect on diagnostic imaging. Do you feel that there is a model by which we could utilize virtual care more readily from our primary care physicians, and even from an emergency perspective, to be able to reduce the burden that we're seeing, but also while providing safe and efficacious care to these patients as well?
Oh, that's a great question, Josh. Virtual care was actually going to be one of my proposed solutions in the talk, but just purely ran out of time. I think that virtual care is here to stay. And overall, I think it's a really good thing. I think that the way it's been implemented, especially with the rush during the pandemic and people not necessarily knowing how to work it into their practice safely, has led to some of the issues like a potential for overuse of antibiotics or testing. Again, I don't think the evidence bears that out yet, but I do have suspicions, like many of us, because I've just heard so many cases of kids who have been treated for otitis media over a virtual care platform without anyone looking in their ears. I think that we absolutely, especially in such a vast country, need virtual care. I think when we deliver virtual care, we just need to make sure that it is appropriate, and the CPSO has released more guidelines on this. I think it's particularly powerful in interventions where maybe you do have that longitudinal relationship with your provider, your family doctor knows you, they're just following up on a known condition. This is excellent. It can save patients and providers so much money. My partner is a radiation oncologist, and now the vast majority of his patients actually see him through virtual care, through over the phone, and they tend to really like it because their catchment area is huge and people don't always want to drive in from 2 hours away just for a follow-up, for somebody to ask you, how are you doing? How are you feeling? So I do think we need to have virtual care in the system as much as possible. We need to make sure it's publicly funded. One of the reasons why we've had these private pay virtual care platforms is because per the Canada Health Act, you can't charge privately for services that are already covered under provincial territorial health plans. I cannot, make a standalone ED and say, I'll fix all your lacerations if you pay me $30. I can't do that. It's not permitted. But in virtual care, because a lot of virtual modalities weren't covered under provincial territorial health plans, a lot of these platforms were able to come up. And now that virtual care is being covered, we're still in limbo. The fees keep getting extended and then for another few months. I think it'll be really interesting to see what happens to them. I hope that they stay, but I hope that they shift more to a public funding model so that there's not those extra costs to patients. Thanks for the question. Oh, and in the ED, we actually had a virtual ED, which I have unpublished data from a manuscript I've been working on for ages and just haven't put together, but it actually saved our system a decent amount of money and was very highly liked by patients and providers. We just didn't have enough staff to keep it going. So that's actually another area where in the future, if we have more staff, we could look at revamping it up.
Awesome. Looking forward to reading about that.
Some really interesting comments in the chat. As Dr. Netto says, at some point, patients have to be seen in person for many things, as well as Dr. Kavesi's statement about, the perhaps some role modeling or teaching about that is somewhat negative about the value of family physicians, which is a big problem in our current state of, training and health at the moment with, what we expect family physicians to do and our opinions of them. As you say, Dr. Bechard, they're the most valuable part of the system and they don't receive nearly the value or acknowledgement that they should. Dr. Maharaj, final question.
I think you're muted.
I think you're muted, Gani.
Sorry about that. Thank you very much for a very stimulating and thought-provoking talk, Dr. Bechard. Very, very much enjoyed it. A bit of a comment and a question. One is, the whole thing, as I'm sure we'd all admit, is so incredibly complex. Trying to fix it is a little bit like trying to solve a fight between your kids. Nobody's completely right, nobody's completely wrong. So it's a little bit tough figuring out where to address your efforts at. One of the things, though, that struck me listening to you talk is when we compare the standard of care that we're providing, it's always relative to other countries, whether we're better off or worse off than country X and Y. And I guess one of the thoughts came up was, is there a denominator? Is there like a standard of care saying that we should be doing this? And so rather than saying, well, we're better off than this country, or we're, are we achieving what we've all agreed as medical professionals internationally is a acceptable standard of care?
Yeah, that's a great question. I always like to say when you're comparing international health systems, you're not comparing apples to oranges, you're comparing like apples to toasters because the populations are so different, the geography is different, social determinants of health are so different. So it makes it really challenging. I think we can learn some lessons, but it's not a perfect comparison. There is one tool, oh my gosh, I think it's called the HMAT or HDAT. I'd have to find it, but it is developed, I think, by Danielle Martin, or at least I found out about it from one of her talks, where it's a way to kind of look at health programs and assess their effectiveness in kind of a standalone, more objective way, and just goes through various questions and quality metrics. So we do have some things like this that exist, but it's really meant to evaluate more specific programs rather than health systems in general. I'm not aware of any way to evaluate health systems in general in a more objective way, but I think that could be a great program of research for someone. I know that there's people who do entire master's degrees in like comparative health systems. But yeah, I'm not sure if we currently have a great way to compare and contrast them more objectively.
Thanks.
Okay, folks, thanks everybody. So there are a couple of other hands up, but we are at time. So I'm sure that for anyone who does have outstanding questions, Melanie would be happy to answer you in a different forum. A reminder to everyone, the link for the evaluation is in the chat, as well as will be sent in a separate email. I'm sure Melanie would be happy to receive evaluations for this talk. Thanks, Melanie, and also thanks to everybody, actually yourself and the audience, for thought-provoking questions and a talk. Obviously very engaging and lots of food for thought. And unfortunately, I don't think we did fix the healthcare system in an hour, but lots of solutions presented. Thanks, everybody.
Thanks for chairing, Hillary. Bye, everyone. Thanks for coming.